We are live now.
Good evening, all. This is Rupesh from Peak Health Studio, Chennai. I would like to welcome you all for the program ExRxIndia is presenting for the students by the students webinar series. I thank Dr. Chandra Mohan, founder of ExRxIndia, Mr. Sampath Kumar, CEO of Sri Samraj Health Service Private Limited, Professor Duna from Dusat's Creation, and I thank all the future physiotherapy graduates who are participating as well as presenting for the world record event for the students by the students webinar series. I take this opportunity to thank all the students also, and today's topic is presented by Miss Aishwarya Sriram from St. John's Medical College on the topic Scapular Dyskinesis. Miss Aishwarya, you can proceed.
Thank you, sir. So, good evening, everyone. I'm Aishwarya Sriram from St. John's Medical College, and I'm a third year BPT student. Before going into the topic, I would like to extend my gratitude to the EXRX team, Dr. Chandra Mohan, Dr. Rupesh, and Professor Duna for giving me such an amazing opportunity to present and spread my knowledge on the topic scapular dyskinesis. I would also like to thank my department staff and HOD for constantly supporting me and encouraging me throughout. So the topic for today is scapular dyskinesis. Now, before going into the topic, let us have a look at the anatomy and the biomechanics of the scapula and the shoulder joint. Now, the scapula is a long, flat bone, also known as a shoulder blade, and it is one of the major bridges between the cervical spine, which is our neck, our thoracic spine, and our shoulder joint. And it provides stability as well as mobility to the neck and the shoulder joint. Now, coming to the parts of the scapula, anteriorly, we have the costal surface, which has a subscapular fossa, which provides the attachment for the muscle called as the subscapularis. Then we have the medial border, which provides an attachment for a muscle called as the serratus anterior. This is the inferior angle. This is the lateral border. And this is the infraglenoid tubercle, the supraglenoid tubercle. This is the glenoid cavity into which the head of the humerus attaches. This beak-like structure is called as the coracoid process. Coracoid meaning beak-like, hence the name. This is the suprascapular notch, and this is the superior border. Coming to the posterior view, this is the supraspinatus fossa, into which the supraspinatus attaches. This is the infraspinatus fossa, into which the infraspinatus attaches. This is the spine of the scapula, which finally extends into a large, flat, smooth process called as the acromion process. This is the medial border of the scapula, the inferior angle, and the lateral border of the scapula. Now, moving on to the muscles of the scapula, we have two groups of muscles. First, we have the axioscapular muscles, which is the muscles attaching the scapula to the axial skeleton, which consists of the trapezius, which is divided into the upper trapezius, the middle trapezius, and the lower trapezius. Then we have the levator scapulae, and then we have the rhomboid major as well as minor. The next group is scapulohumeral group, which mainly consists of the rotator cuff muscles, and they're the major dynamic stabilizers of the shoulder joint. And most of them have their attachment to the scapula. So they are as follows. We have the supraspinatus, which attaches here. Then we have the infraspinatus. We have the teres major and the minor. We have the latissimus dorsi. We have the serratus anterior, and we have the deltoids. Now coming to the movements of the scapula. We have 5 major movements. The elevation over here. So elevation is when you try to shrug your shoulders, or when you're trying to lift your arm upward or sideways, the scapula also moves upward. So that's the elevation of the scapula. Depression is where you're just holding your hands downwards, or when you're trying to lift a weight with the palm facing downwards. Then the gravity pulls the scapula downwards, causing the depression. Coming to adduction or retraction, this is when both the scapula are moving towards each other. So it's like you're squeezing the shoulders backwards. So that's when they move towards each other, causing retraction. So any pulling movement, like pulling a door open, or pulling when you're doing an exercise, when you're trying to pull the therapan backwards, that's when you're trying to squeeze your shoulder together and cause the retraction. Abduction, also known as protraction, is where both the scapula are moving away from each other and forward. So that is the protraction. It's when you're trying to push a wall or push any object. That's when you do a protractive movement. Then we have the upward rotation. That is again when the scapula is moving outward and upward, it rotates. So that's when you're trying to elevate your hand either forward or sideways, the movement occurs. And when you're returning back to the original position, the downward rotation occurs. Now, coming to the muscles that are responsible for the movements. So, the upper trapezius, the levator scapulae, and the rhomboids are the elevators of the scapula. The pectoralis minor, the serratus anterior, and the inferior trapezius or the lower trapezius is the depressor of the scapula. Coming to the protractors, the pectoralis minor, which is mainly present in the anterior or the front portion of the chest, and then we have the serratus anterior, which is present in the side portion of the thorax. Then coming to the retraction, rhomboids, the middle trapezius, the latissimus dorsi are responsible for the retraction. And then finally to the rotations, the upward rotation is caused by a co-contraction of the upper trapezius, the lower trapezius, and the serratus anterior. And the lower and the depressing or the downward rotation is done by the pectoralis minor, the levator scapulae, the rhomboid, as well as the latissimus dorsi. Now, coming to the topic of today, scapular dyskinesis. Now, dyskinesis itself translates into abnormal movement. Dys meaning abnormal, kinesis meaning movement. So, the word means abnormal movement of the scapula when you are moving the shoulder in different directions. And it's the major cause of any type of shoulder pain and any shoulder dysfunction. Coming to the causes of scapular dyskinesis, there are four causes. It can either be shoulder related causes, neck related causes, posture related causes, neurological and soft tissue related causes. Now, coming to shoulder related causes. Now, any type of a shoulder pathology or a disease is mainly accompanied by a degree of abnormal scapular movement and position. Why? Because we have at least 15 of the shoulder muscles that attach to the scapula. So, when there is any problem in the shoulder joint, directly or indirectly, the stabilization of the scapula is not happening because of the weakness of the muscles. So, they're not able to hold the scapula in position, thereby causing an abnormal positioning as well as a movement. The following conditions are major causes for the scapular dyskinesis. Acromioclavicular instability. Why? Because mainly the scapulothoracic joint is related to the movement of the acromioclavicular joint. So when there is some instability in this joint, then automatically the scapula, which is stabilized by the certain muscles attaching to it, is not being held in position properly and thereby cannot be moved also properly. Now, shoulder impingement, mainly if you can see this picture, the supraspinatus tendon is going into this subacromial space. When there is an impingement, it's pressing on the supraspinatus muscle, thereby causing an injury and a compression. So when this happens, the muscle automatically weakens and therefore it's not holding the scapula properly, thereby causing a dyskinesis. Rotator cuff injuries, we all know that the rotator cuff muscles, which include the supraspinatus, the infraspinatus, the teres minor, as well as the subscapularis, along with the deltoid, form the dynamic stabilizing force couple for the shoulder joint. So when they are injured, when there is a tear or any kind of instability in the rotator cuff, then they are not able to hold the scapula in position, especially when it's moving, because they're the dynamic stabilizers, therefore causing abnormal movement of the scapula. Then the remaining three, the glenoid labrum injuries, clavicle fracture, and nerve related injuries, we will have a look at later. Now, coming also, the scapular dyskinesis also interferes with the scapulohumeral rhythm, because what is the scapulohumeral rhythm? It's nothing but the movement of the glenohumeral joint to the scapulothoracic joint in the ratio of 2:1, especially occurs when you're abducting your arm. Okay, so when there is a shoulder pathology, when the scapula is not moving properly because of instability, obviously the scapulohumeral rhythm also is disturbed. Now, coming to the neck related causes, we have two main causes: the mechanical neck pain syndromes and the cervical nerve root related syndromes. Now, mechanical neck pain syndrome is nothing but any disease or a pathology that causes the degeneration of the cervical spine and the surrounding joints, or if the muscles are getting fatigued or imbalanced, then it causes a scapular dyskinesis. Why? Because certain muscles such as your trapezius and your levator scapulae, your rhomboids, they all arise from that region, from the neck, and it goes down and attaches to the scapula. So when there is a fatigue or an imbalance, they become weak. The muscles become weak. When they become weak, they don't have enough strength to hold the scapula in position, be it at rest or during motion, thereby causing a abnormal scapular movement as well as a position, causing a dyskinesis. And cervical nerve root related syndromes is, we all know that most of the muscles of the scapula or the shoulder, for that fact, is actually supplied by the C5 C6 nerve roots of the brachial plexus, and also the trapezius is by the spinal accessory nerve. Now, when this any of the cervical nerve roots are getting impinged or compressed, or if there is an injury or a palsy, then the supply to the muscle is also getting hindered. And when that happens, the muscle gets weak, the muscle gets malfunctioned or dysfunction, thereby causing a dyskinesis. As we all know, the muscles are the major stabilizers as well as the mobilizers of the scapula, thereby causing the dyskinesis. Coming to the posture related causes. Now, excessive thoracic kyphosis, as you can see in this picture, which is like a hunchback, or excessive cervical lordosis, as you can see in this picture, like a forward neck posture, alters the resting position of the scapula. The reason being, if you take the forward neck posture, for example, what happens is the upper cervical spine goes into an excessive hyperextension. So the lordosis is increased, but the lower cervical spine, it flattens the lordotic curve. So what happens here? The flexors, the deep cervical flexors, mainly consisting of the longest scoli and the longest capitis, they lengthen. Along with the scapular stabilizers like your rhomboids and the serratus and the levator, they all get weak. So they are not able to hold the scapula in place, whether in normal resting position or when you're moving it, because they all have an origin from that area. So when that happens, you have an excessive load on the scapula and there's excessive load on the muscles also. So thereby causing a postural malfunction, thereby causing a dyskinesis of the scapula. Now, when you come to the kyphosis, what happens in kyphosis? There's an increased posterior convexity or the posterior curvature of the thoracic spine. So when this happens, what happens is the anterior structures, mainly your pectoral muscles, they tighten. So what they do is they pull the scapula forward, mainly your pectoralis minor, and thereby causing a rounded shoulders. It causes the kyphosis, thereby malfunctioning the malfunction of the scapula occurs and thereby causing a dyskinesis. And the most susceptible population to this is the athletes. Now, mainly the athletic group that involves swimming, volleyball, and tennis, as you can see here, they all, what happens is they use excessive shoulder movements. So, if you take swimming, for example, when you do your breaststroke or when you do a butterfly stroke, it's a quick and repetitive movement. So, what happens there? You're trying to add excessive load and fatigue on the shoulder joint. So when that happens, if you have not trained your muscles well and if you're not having a proper scapular control or stability, then there will be, it's an overuse, it causes an overuse syndrome, thereby causing the dyskinesis, because there will be weakness and instability and thereby lack of scapular positioning. Now coming to the neurological and soft tissue causes. So the major causes are your cervical radiculopathy, that is when you have a tingling sensation throughout from the neck going up to your arm. Why does that happen? Because one of the cervical nerve roots have been impinged, have been compressed, or have been palsied. So when that happens, obviously the nerve supply and the impulse transmission to the muscles of the scapula and the shoulder is getting hindered. When that happens, it becomes weak. When weakness occurs, it's reduced strength to hold the scapula in position, as you can see here, and therefore it gets displaced from its resting position and movement. The next one is a long thoracic nerve palsy. Now the serratus anterior nerve supply is a long thoracic nerve. Now when that gets palsied or paralyzed, the serratus anterior also get paralyzed, and therefore the serratus anterior cannot control the internal rotation of the scapula, thereby causing excessive internal rotation and causing a winging of the scapula. Spinal accessory nerve palsy. The spinal accessory nerve is a nerve supply for the trapezius muscle, and therefore, when that gets palsied, the trapezius also gets paralyzed and weak, so it cannot hold it doesn't hold the scapula in position, thereby causing an elevation of the scapula and upward rotation of the scapula. So that will be the resting position. GIRD is nothing but the glenohumeral internal rotation deficit and the hypomobility of the shoulder joint. Both of them together mainly it's because of the lack of altered muscle pattern. Muscle weakness and muscle stability is reduced. So thereby the scapula is not held in position, causing dyskinesis. Now, coming to the types, it's known as the Kibler's classification. There are four types. Type 1 scapular dyskinesis is mainly the inferior angle. Sometimes there will be an inferior medial scapular border prominence, but mainly is the inferior angle prominence. Type 2 is when the medial border of the scapula is prominent. Type 3 is when the superior medial border of the scapula is prominent. And type 4 is the 6 scapula. Now, 6 scapula is a mnemonic for the following. S is the scapular malpositioning. As I said, it's not being held properly in the resting position. It's displayed either upwards, sideways, inwards. Then I stands for the inferior medial border prominence. C stands for coracoid pain and malpositioning that occurs when there is any shoulder related pathology. And K stands for kinetic abnormalities of the scapula where the scapula does not move properly. As you can see here, this is type 1 where the inferior medial border is prominent. Type 2, the medial border is very prominent. And type 3 is where the superior medial border is prominent. Coming to the clinical features, one of the main features, as I've already said, is the prominence of any of the scapular borders based on the type. Please note that the type that the person presents with need not be isolated to only one. They can have a mixture of two or more types. So a person does not necessarily have to have a type 1. They can have a type 1 and type 2 together. Now coming to the next is the pain. Now there will be pain either in the anterior or the posterior superior or the lateral aspect of the arm. Then there will be limited range of motion. Then there will be muscle tightness as well as weakness, and there will be tenderness on palpation. Coming to clinical assessment. Now, the direct observation, before we go on to any special test or before we use any hands on techniques to assess the individual, we first have to observe the individual at rest and during motion. So when the individual is at rest, you ask them to keep their hand to the side of the body or on their waist, and then you have to observe if there is any border prominence of the scapula or if there is any abnormal positioning, whether the scapula is tilted inward, outward, upward, downward. Then you have to ask them to move their arm actively, either upward, that is a shoulder flexion, or sideways, which is abduction. And then you can see how the scapula moves. So you can see the mechanics of the scapula is being altered and how the prominence of the borders occurs. Next, we have the manual assisted movements. So this is where your therapist provides an assistant during the movement, and then you try to check. Now, this is done by the two tests called as the scapular retraction and the scapular reposition test. Now, coming to the which we'll be talking later. The next one is assessment of the surrounding structures. So, to rule out any other cause or to confirm a particular cause of the scapular dyskinesis, we have to assess the surrounding structures such as the glenoid labrum, the bursa, the capsule, as well as the surrounding muscles. Now, the special tests, the scapular retraction, the scapular reposition, the lateral slide test, then the scapular pinch test, the scapular load test, and the wall push-up test. Coming to the scapular assistance test, so the scapular assistance test, in this test, what happens is the therapist place the hand on the scapula to stabilize it, and then the patient is asked to elevate their arm. When elevating the arm, if the pain is reduced and if the range of motion is increased because of the assistance, then it is a confirmatory sign or a positive sign for scapular dyskinesis. Next one is the scapular reposition or retraction test. So here what happens is one hand of the therapist is placed on the scapula where the medial border is pushed and giving a posterior tilting to the scapula. That is, you're pushing the inner inferior angle forward and the posterior superior angle is coming backward. And then the other hand is placed on the shoulder, as you can see here, and the patient is asked to elevate their arm. So when they are doing this, the pain might reduce if they have a scapular dyskinesis, and the range will also increase. Next one is a lateral slide test. The lateral slide test is mainly done with three measurements. One first measurement is done in the from the inferior angle of the scapula to the T9. Then the second is from the superior medial angle to the T2 level, and then from the spine of the scapula to the T3 or T2 level. Okay, and it's done in three different positions. One is standing with the hands to the side of the body, then standing with the hands on the waist. And the third one is standing with the arms abducted to 90 degrees in an empty can position with maximum internal rotation. Now, when you're measuring these at three different levels, if the difference is the distance is greater than 1.5 to 2 centimeters, then it confirms a scapular dyskinesis. Next one, we have the scapular pinch test. So here the patient was asked to stand and squeeze the scapula backwards. That is, you retract the scapula and then hold it for 15 to 20 seconds. Normal individuals can hold it for 15 to 20 seconds without any burning or pinching sensation or pain. But a person with scapular dyskinesis will not even be able to hold it for 5 to 10 seconds, and they will have extreme burning and pain. You will also be able to see that the contraction is weakening by the second. They're not able to hold the position. And the next one, we have the scapular load test. I'm sorry, I don't have a picture for it, but what you do is you keep a manual load on the anterior, posterior, superior, and inferior aspect of the arm, and then you have to see if the scapula moves. Now, if the scapula moves by more than 1.5 centimeters, then it is a confirmatory sign. Coming to the wall push-up test, so here it's mainly to see if there is a winging of the scapula, and it mainly assesses the serratus anterior function. So you ask the patient or the individual to do 15 to 20 repetitions of the wall push-ups. And if a person has a weakness of the serratus anterior, then within 5 to 10 repetitions of the wall push-up, the medial winging, as you can see here, of the scapula occurs. Now, if you're dealing with an athlete or a stronger individual, you can also perform this test on the floor. Now, coming to the final topic, which is the treatment of scapular dyskinesis. Now, treatment is mainly based on the muscles that are affected, the type of the kinesis, and the cause of the dyskinesis. So if it's because of the lack of soft tissue flexibility, like if you have tightness of the scapular or the glenohumeral muscles, or if the capsule is tight, or if you have any other tear of the glenoid labrum, then what you have to do is you have to fix it. Now, why is it important? It's because when you have tightness of muscles, the moment there will be restricted range of motion and there will be pain. Okay. And also when you are restricted range of motion, then you have to do mobilization to improve the range of motion and reduce pain, and stretching to reduce the tightness of the muscles and the capsules. So that's how. So mainly you try to focus on the pectoralis minor, the levator scapulae, and the rhomboids, but trapezius also is very important to be stretched and strengthened. Posterior capsule stretching, infraspinatus, latissimus dorsi, and the rotator cuff also have to be stretched and strengthened. Now coming to the final algorithm. So you can do manual stretching, you can do self-stretching exercises at home, you can do soft tissue techniques to release if there is any tightness, if there is any pain, any muscle spasm, or a trigger point or a taut band present. So you can do massage, you can do transverse friction massage, you can do trigger point release, you can do spasm release, you can do massages. So you can do all that to relax the muscle and relieve the tension and tightness. Next one is a manual mobilization. Mainly you do this with accessory movements. You can use a Maitland form of mobilization for soft tissue. Mainly what you do is the patient is in the side lying position and scapular mobilization is given. So that can be done. First, initially you give grade 1 and grade 2 to reduce the pain, and then gradually progress to grade 3 and grade 4 of Maitland mobilization for the scapula. If the shoulder range of motion is also affected, you can go ahead and also give the shoulder either anterior glide, posterior glide, depending on the movement that is affected. Mobilization with movement is here, it improves the range of motion because the glides are given along with the motion. So if you're trying to elevate the arm, you're giving the glide when you're elevating the arm. So that helps to push the joint further beyond the range of motion of restriction. So that helps to improve the range of motion. This is a Mulligan concept. Now coming to the muscle related pathology. So if the muscle performance is reduced, there are two components: muscle control that helps in stability, and muscle strength that helps to hold the scapula in place. So when both of them are disrupted, the stability and the mobility are affected. So to get it back, you have to work on the proprioceptive facilitation of the individual. You have to work on balance. You have to work on coordination, strength, and endurance. Okay, now coming to the rehabilitation phases, there are three phases: acute phase, the recovery phase, and the maintenance phase. Now, in the acute phase, it is mainly from 0 to 3 weeks. Now, since it's an acute phase, what happens is there will be excessive pain and restricted range of motion and tightness of the muscles. So you do not want to push them beyond the pain limit. So you have to make sure that they are rested well. You do not do any movements that causes pain, or you do not position them in any position that causes pain. Okay, and then slowly you can start off with, for improving the range of motion, you can start off with passive range of motion initially, then active assisted range of motion, active motion, and finally you can go on to proprioceptive neuromuscular facilitation. So here what happens is you use a D1, D2 concept. That is, you try to move the shoulder in different patterns. Like if you take one of the patterns is if you take the flexion, external rotation of the and abduction of the shoulder. Then you go on to extension, adduction, and internal rotation of the shoulder. So that is one of the patterns. So that helps to improve the range of motion as well as stretches the muscles. The next one is going to be the stretching and soft tissue mobilization. So depending on the muscles that are affected, you stretch the muscles. Either you can do it with a therapist, or there are self-stretching techniques as well. So mainly you pay attention to the trapezius, the latissimus dorsi, levator scapulae, pectoralis, infraspinatus, and the teres minor muscles. This helps to reduce the tightness and improve muscle flexibility. So stretching starts with 5 to 10 seconds, and then you gradually progress to 15, 20, 30 seconds of 2 to 3 sets each, 2 to 3 times a day. So you can also start with upper extremity weight shifting with the wobble board. So what you do is I will show you the picture. So in this, you can see this is a wobble board. So what happens is you ask the person to go into a push-up position and you try to balance. First, start off with static balance where they have to just place their palm on the wobble board and stay for a few seconds, start with 5 to 10 seconds and then increase gradually. And once they have achieved good control over here, then what they can do is they can move their hands side to side and they can do reach outs. All that can be progressed. Okay, the next one, what you can do is you can also start off with something called as there's something called as kinesiotaping. Okay, so the kinesiotaping helps to immobilize the joint, and it also helps reduce the pain, and it prevents any type of compensatory movement like a shrug or a winging, which is pretty natural in such positions because we all we adapt to positions that reduce the pain. So to prevent that, we do a kinesiotaping. Now, this is a rhythmic ball stabilization exercises where the switch ball or a Bosu ball can be placed against the surface and you press against it, and then you can rotate it, which is called as a scapular clock exercises. So there's something called as a YTW exercise. That is, the person lies in prone, okay, and then when the arms are spread out like this, it's the Y position. Then when it's spread out like this, it's the T position, and when it's backwards, it's like a W position, hence the name. So initially you do it without any weights. It's a freehand movement, open kinetic chain movement, because we are not in contact with any surface. And the next one, so these are the stretches. This is the rhomboids as well as the posterior capsule stretch. This is the trapezius or the levator scapulae stretch. This is the pectoralis major stretch, minor stretch, and the serratus anterior stretching. Moving on to the recovery phase, which is between 3rd to 8 weeks. So first, once the range of motion is improved and once the scapular control is bought, at least made decent enough, then the scapular strengthening as well as the motion is worked on to improve the motion, to improve the posture, because sometimes they go into an adaptive false posture like a forward neck and a a kyphosis. So you try to prevent it. So initially you can start off with closed kinetic chain exercises like a prone modified push-up with the knees in contact with the ground, or you can do table wall push-ups. You can also increase the level of closed kinetic chain exercises. And then you can also improve the arm elevation and rotation patterns. Now, I'm sorry, I forgot to mention that in the acute phase, you do not take abduction beyond 90 degrees and you always start from 0 degrees and slowly progress. And elevation is not done at all. We always use the trunk position. Like when you're trying to twist your trunk inward, then you're doing a protraction. And when you're trying to twist your trunk outward, then it is your retraction. So that's how you try to initiate the movements. Then further, you can also use dumbbells. You can start with strengthening exercises with light or low resistance. You can use TheraTubes, you can use TheraBands, you can use light dumbbells, you can use weight cuffs, and then slowly progress from light. Start with 5 to 10 repetitions. Then before going on to the next resistance, improve the repetitions to 10 to 15. Then move on to medium resistance. Again, increase the count and then move on to high resistance. You can do, as I said, remember the YTW exercises that I told. Now you can do it in prone position with dumbbells of light weight and moderate, and make sure they did not do any compensatory movement. And finally, the maintenance phase, which is from 6 to 10 weeks. Here, once you get good scapular control and good muscle strength, you have to maintain it so that it doesn't recur. The scapular dyskinesis shouldn't recur. So when you want to maintain it, you do these. You can start with plyometric exercises, which are nothing but low impact strengthening and flexibility exercises. So you can start off with plyometric tubing exercises. You can do medicine ball tosses. You can do catches. You can do in the wall. Even you can progress your wobble board exercises for balance and coordination. You can stand on the wobble board and do medical ball tosses and all that. Then you can do tubing exercises. Here you can do retraction. You can do scapular punches. First, you can do scapular punches without any weights. Then you can use this band to help to improve the strength. Again, the YTW exercises will be progressed. Any overhead dumbbell presses and dumbbell punches can be done to improve the range of motion as well as strength. So that comes to the end of my presentation. These are my references. Thank you for joining and hope you guys have a good day.
Well done, Miss Aishwarya Sriram.
Thank you, sir.
So it was very good core topic of the shoulder, as it is helpful in balancing the upper body structures and stability.
Yes, sir.
So I take this honor to thank Annie Thomas ma'am again for giving us many wonderful presenters for this top for the students by the students webinar series. And I thank your guide or anyone who helped this topic for presenting in such a way to reach all the physiotherapy students. Thank you, and we'll meet forward in the next session. Bye bye.